Welcome to PROCURE Health Talks, a webinar specially designed for men affected by prostate cancer and their loved ones. The various topics covered in these webinars are intended to provide reliable information based on the concerns and questions asked to PROCURE healthcare professionals. Let's begin.
Hello, my name is Thierry Dujardin. I'm a urologist-oncologist at the Surgeon-Urologist de Québec, and I'm going to talk to you specifically about radical surgery. As you know, radical surgery is one possible treatment for prostate cancer, and I'm going to try to be very practical during this presentation, just as I am with patients who have been diagnosed with prostate cancer, and I'm helping them make choices about their path going forward. In general, when patients have been diagnosed with prostate cancer, they have already had a biopsy. A prostate biopsy is what allows us to determine the disease's risk, the score, and the grade. I'm just going to refresh your memory a little bit here because this is what guides our treatment choices. We have to differentiate between the Gleason score, and I think that every patient who has had a biopsy knows his Gleason score and what was found on the biopsy. That score is an index of how aggressive the disease is. There are low-risk tumors and there are high-risk tumors, and I would say that that is basically how we differentiate treatment from one patient to another. It's not the only factor because we also look at the overall workup of that disease. Every patient who has been diagnosed with prostate cancer has to have a full workup, which is how we stage the disease. So we explain to patients that we are going to do an abdominopelvic and thoracic scan or a bone scan, or more often, the option we use is magnetic resonance imaging. A prostate MRI, just like an abdominopelvic MRI, is something that we use and that gives very good results. The problem is that in Quebec, it is not always available in a reasonable amount of time, and that is why sometimes we don't use it. Once the patient has had his biopsy and we have that index for the seriousness, the Gleason score that goes from 6 to 10, we can determine the stage of the disease. Often patients mix up stage and grade. So the stage is a combination of the digital rectal examination along with the biopsy, which gives us that index of the disease's aggressiveness, the Gleason score from 6 to 10, and the expanded workup with an MRI or a scan. Once we have done all of that, we can determine what is the patient's situation, what is his stage. Is the disease localized in the prostate? Has it grown slightly beyond the prostate, or has it progressed very distantly from the prostate? This is an important thing, and that's why we discuss this with the patient to make a strategic therapy plan. We need all of these pieces of data because we are going to distinguish between certain patients that are going to be treated locally in the hope of curing them versus those patients who, unfortunately, their disease was diagnosed a bit later and the disease has progressed. We cannot cure them, but we can extend their lives and manage the evolution of that disease. This is critical even before we talk with the patient. That is what determines the progression of our disease. We have to have that discussion, and we have to distinguish between low risk, intermediate risk, and very aggressive risk, or there is a risk that my disease has grown beyond my prostate. That is critical before we talk about treatment with these patients. When we talk about treatment and this classification of is my risk low, aggressive, or do I have high risk, overall, you know that it is not always easy for a patient who is deciding his path forward to make those decisions, or with data that he can understand that we have given him. We have to give that patient some context. Is this a patient that we can just monitor or who needs treatment? And if this patient needs treatment, what type of treatment? Surgery or radiation therapy? And here again, risk is important. If you have low risk, you can have all of these treatments. If you have intermediate or aggressive risk, treatment is still possible, but we're going to be combining radiotherapy, hormone therapy, usually for a fairly long duration of treatment. I won't talk about radiotherapy today because my subject is focusing here mostly on radical surgery. But this is what I always tell patients when you have a decision to make. It is not the same treatment for everyone. It's not like we have a hammer and we just drive the nail in the same way every time, because every patient is different. We have patients who, depending on their overall state of health, their age, or their life expectancy, are going to have different decisions to make. When you get diagnosed with prostate cancer, if you're 55, it's not at all the same thing as a man who's 76. If we diagnose someone with an aggressive cancer, it's not at all the same thing as a slow-growing cancer. And also, in addition to the person's overall state of health, we are going to look at erection and incontinence, because those are important variables. Because as you already know, when you are treated for prostate cancer, you potentially have side effects related to those two things. I say this all the time to my patients. If I give you a treatment for your prostate, some people are going to have a lower sex drive, problems with erection or ejaculation. When we operate with a scalpel, or if you have radiation therapy, then we are going to affect those things as well. It's very important to know what is our patient's opinion on this, and especially what are his values. Some patients are going to say, I don't want to talk about this at all. My erections are good. I don't want to take any risks with that, regardless of the state of my cancer. And that's an important factor. Some, on the other hand, when we talk about erections, it's not an issue anymore. It's not a problem for them in their relationship. And for those patients, we know that they are going to be treated very differently. So as you see, we have to take the time to evaluate all of that, because death from the disease is different from death related to the disease's progression. And those mortality risks, we could call those competing factors, meaning that in a 70-year-old patient, in the upcoming 10 or 15 years, that patient has often a higher risk, depending on the state of his cancer, of dying from something other than prostate cancer. So that is critical to have as a decision-making factor. Radical surgery, as you know, because your urologist has undoubtedly talked to you about it, it involves removing the prostate, and we can do that with a classic traditional surgery technique, meaning that we use a scalpel and are right in the patient's abdomen. And we can also do that through laparoscopy, where we use small surgical rods and we work indirectly via a television screen. And now for about 15 years in Canada, in Quebec, we have had the possibility of doing robotic surgery. So we have 3 options. So what is the appeal of radical surgery? Because that's often something that patients have a hard time understanding at the outset. When they ask themselves, what is the advantage of removing my prostate rather than having radiation treatment and leaving it there? Because at the outset, patients feel that the impact is going to be worse on all of their body functions. The appeal is that we can analyze the result, meaning that when we remove the prostate, we send it for a histologic analysis, and that allows us to know where the tumor is. Was it confined to the prostate? Had it gone beyond the prostate? Are the lymph nodes involved or not? So we have real staging. The other factor is that a patient who has had his prostate removed, when everything goes well, his PSA level is 0. And patients can understand that. They come because they have a high PSA level. We take their prostate out. The PSA is 0. Everything is great, and they are reassured. The other important factor to take into consideration is that a patient who has been operated on, if he has a recurrence, we can always do radiation therapy as a secondary treatment, which we might call a complementary or additional treatment. And that works in one direction, but not always in the other direction. When patients have radiation therapy first, if they have a recurrence and we need a secondary treatment, it is always more complicated to do surgery. It works well in one direction, but not in the other. Those are the advantages. Now, let's talk about disadvantages, patients who have to be operated on. We always have operatory risks and general anesthesia, staying in the hospital, recovery time, having a temporary bladder catheter, and potentially some complications, which we know about in terms of urination and sexual function. But I'll talk about that in a little more detail later. Surgery works, meaning that just like radiation therapy, prostate cancer is very treatable. It all depends on the stage when we're doing that treatment. Same thing. We have good results over long periods periods of time, knowing that those results, if you have medium risk, which is the most frequent, 90-95% cure rates over the long term. And I'll just go on a little tangent here to tell you that in some cases, in patients who are low risk with slow growing cancers, we have published data now looking at results over 10 years, 15 years, who show that for those patients of low risk or maybe some component of medium risk, at 15 years out, the risk of dying of cancer is only 3%, even in a cohort of patients that was monitored, meaning that active monitoring, active surveillance for some patients is an appropriate treatment. So we always have to have this discussion with our patients. Just because you have cancer doesn't mean you need treatment. That's an important message, and you really have to talk to your urologist when you go for an appointment about that. Radical surgery involves taking out the entire prostate. As you know, the prostate sits right near the bladder, near the ureter. So we section the ureter, we section the neck of the bladder, and then we resection. Lots of patients ask, but isn't this going to shorten my penis? We don't touch your penis at all. It is just the neck of the bladder. Often in terms of potential complications, we have urinary complications and sexual function complications. And here's an analogy I really like. When I explain to prostate surgery patients and I tell them, imagine you have an egg in an egg cup. Surgery involves taking out the egg without touching the egg cup. So we have to go between the egg and the egg cup without cutting into the egg or the egg cup. That is what allows us to maintain those little nerves that control erection. Because when we talk about nerves and patients will ask me, were you able to keep my nerves in place? They feel like there's one big nerve that is obvious and that we can see, but in reality, it's like a net of small, often invisible nerves that are about the width of a hair. So even when we can keep them, we pull on them, and that's what explains that sometimes erections after surgery take some time to get back. So using this egg cup image is appealing because people understand it. And when the disease is completely confined to the prostate, we know that we can get that egg out without cutting into the egg cup. But when the disease is close to the margins, we have to cut into the egg cup. After surgery, the more intact the egg cup is, the better the chance is that the patient will recover his erectile function. Another question that we often get is, how do I choose between surgery and radiation therapy? I went to see my urologist and he told me that he did classic surgery where he would open me up because he doesn't do robotic surgery or laparoscopy. I tell patients all the time, if you have the option to be operated on by someone who does classic traditional surgery but has been doing that 10, 15, 20 years, it is because that person is good at it and you should do that. Non-robotic surgery, it doesn't mean it's not going to be good. It is important to know who is operating on you. And these technological tools where we can magnify the image, it improves performance, but someone who is well trained in classic surgery is going to have good results. The real difference between open abdomen surgery and laparoscopy is particularly with blood loss, the risk of needing a transfusion, and leaving the hospital faster. In general, patients worry about their erectile function and their urinary function. That is a question that we have to take time and explain very well so that patients know what is going on there, because sometimes they get a little confused. So if we look at urinary function, that is often temporary. Patients who are going to be operated on have to prepare for that surgery. Very often men have no idea what the pelvic floor is. And I tell them it's a muscle, you have to exercise it. They don't know where it is. They can contract their stomach, their buttocks, but not their pelvic floor. And personally, I send all my patients to physiotherapy so that they can be evaluated and get some exercises, because that is how you strengthen your pelvic floor, and that minimizes the impact after surgery. Incontinence after the operation is normal. We tell patients that all the time, that you're going to have some loss of urine. But if you do your exercises and as time goes by, you're going to recover. And we have statistics on that. And after a year, the results are satisfactory in people who do their pelvic floor exercises regularly. About 90% of patients after a year will be wearing no protection, or they wear protection just as a precaution. Severe incontinence is about 10% of patients, and that can be treated secondarily if necessary. And in terms of erections, that's more complicated because it's multifactorial and depends on the sexual dynamic between the couple. Is there stimulation or not? What was the patient's erectile function before the operation? We're often surprised because we'll ask patients, how is your erection? And they'll say, oh, it's fine, it's fine, it's fine. But when we ask more questions and we dig in deeper, we realize that that patient hasn't been having penetration for 2 years, 3 years, that they've been having sex less frequently. But in that context, the couple are satisfied and they say, everything's good. So we operate on a patient, they can't get an erection, they don't have rigidity, and we think that they were completely potent beforehand, but they aren't now. And sometimes it's important to know that that's not the case. So that's why it is important to properly evaluate the patient and have that good conversation with him. When it comes to surgery, I was saying just now that it is important to stage the tumor, and that is the reason that we have to remove the lymph nodes. It's part of surgery. A radiation therapist will irradiate the whole area, meaning the prostate and the lymph nodes, whereas we take out the prostate and the lymph nodes. And that allows us to stage the tumor and tell whether a patient with positive lymph nodes needs immediate radiation therapy or not. So when it comes to more practical things like urinary incontinence, the patient has to work on his pelvic floor with a specialized physiotherapist. He has to do exercises every day. And as I was saying just now, a man whose prostate has been removed, his bladder then sits right on the pelvic floor. And often when patients come with their spouses or partners and we talk about statistically what is the difference when you age, it's that women are more likely to have urinary incontinence when they are lifting something, coughing, sneezing, but a man whose prostate has been removed has the same risk factors. So you have to work on that continually. We see patients who put in that effort and then they get to a certain level and they stop doing their Kegel exercises, and then that incontinence comes back. So it is important to work on that and to do it consistently. Erectile function, even if we preserve those nerves, there is going to be a phase when the nerve impulse is not flowing. And as I was saying just now, those little nerves are the size of a hair. So when we pull on them, they have to heal. And when they are not healed, the nerve impulse is not going to flow through. So there will be no swelling or rigidity. That is why you have to take care of that. And in patients who we know had good erectile function before the operation, we have to stimulate them. They have to stimulate themselves using medications like Cialis, like Viagra, using a pump or a vacuum. Sometimes I encourage them to give themselves injections. Those are small needle injections into the penis to promote recovery. Everybody is different. There are patients who really want that rigidity. To them, sex means rigidity. They don't want to wait for those nerve impulses to come back, what we call the healing phase that can take 12 to 18 months. So those patients, we have to educate them about how to give themselves injections. Other patients who have a little more patience for that, they can stimulate themselves with medication, and that works well, pumps or medication. But that is a factor that is key in the decision so that the patient won't be disappointed. And very often we see that patients don't understand this. There's also another message that I think is important in this context, which is to tell a patient who is going to be operated on, you're going to have orgasms. You'll still have sexual pleasure and orgasms, but there will be no sperm and no rigidity at the outset, but all of that will come back bit by bit. We have to separate out orgasms, ejaculation, and erections. Patients have trouble with that, so we have to take the time to explain it to them so that they can understand. All of these factors will potentially come back, but everyone is different in this context. Patients need to be monitored, coached, we need to see them regularly, and they need a team. Nurse navigators, when patients call them, patients have concerns like I was saying just now. They might call PROCURE's hotline where nurses can help patients who don't have access to their doctors or a nurse navigator. We really have to monitor that in detail. Now, after that surgery, that is not the end because a certain percentage of patients whose PSA is 0, negative, are still going to have a recurrence. That is just part of what we deal with. It's not because something failed or there was a mistake. It is just part of the process. So it is important that the patient knows this and that they follow through with their testing. Having blood tests every 3 months or 6 months at their urologist or radiation therapy visit is very important. That's what allows us to identify those patients who are going to have a relapse either early or late and will need an additional treatment. PSA is really critical for monitoring those patients. And often when patients are diagnosed for the first time with prostate cancer, already they've heard the words cancer and prostate. They think that they are going to die soon. This is a process. It's a path. And at the moment that that patient is diagnosed early and they are treated, the first treatment is maybe going to be enough. Sometimes for maybe 15 to 20% of patients, they are going to need a second treatment to get that PSA to 0. Then we have patients who are going to be monitored. Some are going to be cured and some are not. And as I said just now, for low or medium risk, we're looking at cure rates of 90-95%. Lower cure rates for more aggressive diseases, and sometimes when the patient has metastases, we cannot cure them, but we can slow the progression of the disease. With new treatments, new drugs, we are looking at really interesting survival rates, meaning that metastatic patients, and I have some in my patient base, who I have been treating for 8, 9, 10 years. That is a message that we need to give patients, to tell them that we're going to do everything we can to manage this disease and treat them at the time when we can still have a cure and hope that the disease has not spread. But even if the disease has spread, they have years of life ahead of them, and we really have to talk to them about that. So to sum up and just give 2 or 3 takeaways or typical questions that I get in my practice and for patients, and which show the appeal of having surgery, I would say staging the tumor and the possibility of an additional treatment with radiation. Yes, there is incontinence after surgery, which is temporary if you work on it. There is erectile dysfunction, which also has to be addressed. It's like anything else in life. You set yourself up for success, you put in the effort and work at it. The surgeon has done their part to preserve those small nerves, but the patient who wants to get back his erectile function has to put in that same effort. And sometimes patients will say, surgery just seems more aggressive to me than radiation therapy. But with radiation therapy, you also have erectile dysfunction and incontinence. The difference is that it's not stress incontinence, it's more irritation, difficulty urinating, pseudo blockage, or that extreme urge to urinate. There are advantages and disadvantages, and that's why it's important to talk with the patient and not say, this diagnosis means surgery. No, this diagnosis means risk, monitoring, treatment, radiation therapy, surgery. So we really have to take that time to talk with the patient. And in practice, as I was saying, I use the PROCURE site frequently. When patients come to that first appointment and are making treatment decisions, you should never make a treatment decision then. We look at the various factors and the patient has time. We're not in an aggressive situation where the patient has to make a decision in 3 weeks. That patient should use that time to gather information, talk to different people, get opinions, talk to different partners, and then we reevaluate the patient, have another conversation about all those factors before he makes that decision. And I tell patients all the time, your decision will be the right one. They ask what I would do if I were them, but I am not them. I can only give advice. And you have to make the right decision for you, because if you put in the effort to weigh all of these factors, on the day that you decide, it will be the right decision because it will be your decision. And you will accept the positives and negatives because you've thought it over and made your decision. Thank you so much. I hope that this information will be helpful to you.
We warmly thank our experts and our partners for making this webinar possible. To find out more about the tools and resources available to you, or to make a donation, Visit procure.ca. Thank you for your support.